O'Reilly! You've got questions? O'Reilly Auto Parts has answers. Need a pro you can trust? We've got that too. No matter what you need, our professional parts people have the training and expertise to help you do things right. Deep automotive knowledge, just one part that makes O'Reilly stand apart. The professional parts people.
O'Reilly Auto Parts.
Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Welcome. My name is Annie Rogers, and on behalf of the Attitude team, I'd like to thank you for joining today's ADHD Experts presentation titled Emotion Regulation Difficulties in Youth, ADHD Irritability, DMDD, and Bipolar Disorder. Leading today's presentation is Dr. William French. Dr. French is a board-certified child and adolescent psychiatrist in the pediatric clinic at Harborview, Seattle Children's Hospital, and Odessa Brown Children's Clinic in the Division of Psychiatry and Behavioral Medicine. He is also an associate professor at the University of Washington. In today's webinar, we'll discuss the emotional dysregulation associated with ADHD. If your child struggles with anger, irritability, even rejection-sensitive dysphoria, then you know that the ability to manage emotions is often delayed with ADHD, and feelings are often more intense and frequent. But how do we know if emotional dysregulation is just a part of ADHD, or is it something more, like DMDD or oppositional defiant disorder? Here, Dr. French will help caregivers differentiate the likely source of emotion regulation difficulties, a task that is challenging even for seasoned clinicians. We will also discuss how to support kids experiencing irritability. We will begin today's webinar with this poll question for our live audience. What aspect of emotion regulation is most challenging for your child or patient? Please select your answers and comment in the text box under the video player to tell us more. You'll see the poll results when you submit your response. While you do that, I will point out that live participants can download the slides by clicking on the Event Resources section of your webinar screen. The certificate of attendance information will come in an email you will receive around an hour after the live broadcast, and a transcript of today's event will be made available in the coming week. If you are listening in replay or podcast mode, visit attitudemag.com and search podcast 435 to access the slides, webinar replay, certificate of attendance option, and the transcript. If you are still shopping for gifts, Attitude Magazine is offering a 2-for-1 subscription deal now through December 31st. Visit attitudemag.com now to get 2 subscriptions for the price of 1, maybe for a family member or as a holiday teacher gift. Finally, the sponsor of today's webinar is Microvita. The Microvita Probiotic Kit contains 2 probiotics to support focus, attention, healthy gut function, and proper dopamine and serotonin regulation. Microvita Focus contains 6 strains that support attention and focus, while Microvita Mood contains 6 different strains that support mood and emotional regulation. Quality probiotics provide your gut the healthy bacteria it needs to support mental health through the gut-brain axis. Click the link on your screen or visit phoenixhealthscience.com to learn more. Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without any further ado, I'm so pleased to welcome Dr. French. Thank you so much for joining us today and for leading this really important discussion on emotion regulation.
Hello, everyone, and thanks for inviting me to present today. And I have just one disclosure. My name is William French, or Will French, and My disclosures, I do get some NIMH clinical research support, and it is for ADHD. It's actually for treating adult parents of kids that have ADHD or at risk for ADHD, treating the adult parents first with stimulants and behavioral management therapy to see if that can delay the need for their child to be put on a medication for ADHD. So our agenda today, I wanted to present some cases, and this will be a lot about emotional dysregulation, difficulties in kids with ADHD, and particularly I reference you back to Russell Barkley's presentation he did, I think, in August of 2021 on this topic. I think he's a true expert, and I would encourage you to dive deeper into emotional dysregulation associated with ADHD. Part of that is irritability as an emotion. And so we'll be talking about irritability as a nonspecific transdiagnostic symptom that occurs in ADHD, but also many other disorders. And I think that might help us parse out different potential diagnoses. So, and part of using irritability as a symptom, it would be good if we can narrow down a wide differential to fewer potential problems to investigate. And I hope to give you some ideas about how you can take information from today's presentation and improve the care of youth that are suffering from irritability or emotional dysregulation problems. Those ideas will be some general principles, looking at a research study that utilized principles of DBT to approach youth diagnosed with a separate disorder. I'm sure almost everyone knows what this stands for. It's disruptive mood dysregulation disorder. Looking at one trial that's been done on a cohort of kids identified as severe mood dysregulation, which was the precursor to DMDD. And then talk a little bit about horses and zebras. That's a common terminology in the medical world, talking about things that are common and things that are rare, and talking about this in the context of emotional dysregulation across a spectrum of potential disorders. Hopefully we can go back and look at the cases again and then leave enough time for questions. So going on to the cases. So the first case I would like to present is a kiddo, Max B. And he's a 17-year-old that's currently hospitalized. He grew up in an intact household. His parents are still married. His mother suffers from depression, and his maternal grandfather was diagnosed with bipolar and responded well to lithium. So Max showed irritability and depressive symptoms from a fairly young age, around end of elementary school. But trials of antidepressants to treat depressive symptoms have been unsuccessful, and sometimes actually made his mood worse. And he's experienced some suicidal ideation after starting an antidepressants. And then around 15, his parents became concerned for a period of time when his mood seemed really altered from its baseline depressed mood. And he had a decreased need for sleep, but that kind of resolved fairly quickly, and he went back to his kind of baseline state. And so more recently, Max's parents became concerned again because he again started not sleeping well. He was more distractible. He doesn't have a diagnosis of ADHD. His grades fell, and he became much more impulsive and snuck out of the house, took the car, wrecked the car, and using his credit card without their permission. And then his parents became more worried when, not only was he having kind of a more expansive, elated mood, but he was having severe irritability at the same time, way beyond the baseline. And but he also, more than that, his behaviors and speech became so bizarre that they took him to see his pediatrician, and the pediatrician heard from him that he was having some type of visions of God, and that God had told him his purpose was to save the planet from global destruction. And so he was admitted following that office visit. So the second case is Andrea W. So Andrea is a 12-year-old referred for episodic aggression, so aggressive behavior, no history of ADHD. At home, they generally describe her as easy, fun, creative when she's doing kind of familiar activities. But she does have a history of being slow to warm up in new situations, like going out on the playground to meet kids. But functioning. But more recently, she transitioned to a new school, and they noticed she's really a lot more frequently irritable, and she's kind of shutting down about what's going on. And on several occasions, she's become, overtly aggressive with her parents, and on one occasion tried to kick the car window out on the way to school. At school, however, she's generally compliant, somewhat reserved and quiet, but oftentimes when she comes home from school, she gets emotionally escalated and says things like, "I hate school." The third case is Johnny A. So Johnny is a 9-year-old. He has been diagnosed with ADHD. They describe him as a very active and fun-loving kiddo. But prior to being started on a stimulant, his impulsiveness and lack of focus, led to some injuries. He's lost a bunch of stuff, some of which is valuable, and his grades, not given his intelligence, his grades don't really reflect that. And so in the past, before he started treatment, when he'd get in trouble with his friends or at home and at schools, he might deflect the blame, and he might become more irritable with others. But generally, at his baseline, he was generally, shows affection and is well liked. And since he's been in treatment with a stimulant, he doesn't have that much irritability as long as he remembers to take his dose. So our next case is Bert O. So Bert, he's a 14-year-old male that grew up in a household with a lot of chaos, a lot of parental discord, and probably a lot of what we call coercive parenting. So just not kind of healthy parenting style. And his mom, who's raising him now, says that he was always easily frustrated. He was often irritable and grumpy, emotionally reactive, of course, unless you let him do what he wants. And she describes living with him as like walking on eggshells to try to keep things peaceful at home. He had temper tantrums in elementary school, which led to a stimulant trial, but that didn't pan out for him. So he hasn't been diagnosed with ADHD. He didn't do well. Stimulants really didn't make a huge difference in how he was functioning. And over the years, as time has gone on, he's just alienated his teachers and his peers due to these emotional blow-ups and this pattern he has of just getting annoyed without a lot of provocation, and he stays kind of annoyed longer than most people would think, and somewhat resentful. And while his peers, are more mature that way, they might have a little blow up, but they seem to be able to regulate better and move on and get over it. And more recently, he's just more consistently irritable and moody, like more persistently down and not isolating more. And so at a PCP visit, the PCP started to see signs and symptoms of a possible depressive mood state. But Bert so far isn't really opening up about what might be going on. And then finally, there's Stacy E. She is an 11-year-old in the hospital. And so she grew up in a family somewhat like Bert's perhaps, but very hostile. And then her father just didn't do well in school at all, really struggled in school. And he ended up dropping out. And he just hasn't been able to be successful in society and has been in and out of jail since then. And as a child, she was difficult to soothe. She would become irritable with task demands or some type of situation in her environment, which triggered emotional outburst. She's also had, unlike Bert, she really has had a lot of trouble focusing and maintaining personal space and controlling her impulses. So unlike Bert, she was diagnosed with ADHD and has responded to a stimulant, and which has helped with the core ADHD symptoms like attention and impulsivity, and to a certain degree with the emotional outbursts. And then, subsequent to her ADHD diagnosis, she's also been diagnosed with ODD, DMDD, and depression. And so far in the hospital, she's been irritable, hostile, impulsive, emotionally reactive, negative. And her mom says, well, this is pretty much par for the course, especially when she doesn't take her stimulant medications. And one of the docs there, one of the psychiatrists, seeing this kind of ongoing pattern of unsafe behaviors with some self-harm and her poor response to previous treatment, this person has diagnosed her with bipolar and is getting ready to start her on lithium, even though she doesn't really have a family history of bipolar in her family. So those are 5 cases. You might see some of the kind of elements pop up in the next slides that might remind you of these kids, and then later on we can revisit them. So broadly, I wanted to look at irritability as a nonspecific transdiagnostic symptom. Irritability has been a big kind of hot topic at the NIMH that sprung out of their research about severe mood dysregulation that led to the DMD diagnosis, and they're just really have been focusing over the last several years on what is the impact of irritability on the adaptive functioning for youth going through development. So for irritability for us, like for pediatricians, irritability for us is like a fever for a pediatrician. So it's a non-specific symptom we see across a range of disorders. So just like a pediatrician has to work up a fever with more analysis to try to source it back to a specific cause, like a viral illness, so too do we have to try to figure out what irritability represents. So what's going on in my irritable kid's brain? So this schematic is a little confusing even for me, and it's hard to explain simply. And first I should say, when you look at irritability, one definition of irritability is this idea of frustrative non-reward. So, reward doesn't happen, person gets frustrated. And the simplest way I look at this is our only purpose in life is, our motivation is to get as many carrots we can get and avoid as many sticks as we can. And, evolutionarily, we were designed to do that. But, if the biology environment is working well on your behalf, you're getting lots of carrots, you're not getting many sticks. But if you have some type of dysfunction, could be biological, like a genetic risk. It could be the home environment where, and the home environment could have kind of, a failing to set the stage for carrots and avoidance of sticks. And that process listed there is called instrumental learning. It's also called operant learning, but it's based upon the simple idea that that consequences actually select for subsequent behaviors. So if you do something and you get a reward, we generally want to do the same thing over. And as far as avoiding sticks, like we generally want to avoid like snakes or hot stoves. But if you have kind of malfunction in one or both of those systems, then it kind of it's a little more challenging. All bets are off the table because then you have a system that's not working well, either the individual or their environment or both. And as a result, when you don't have that system working well, you get less carrots and possibly more sticks, and then the response to that can be these emotional responses of easily becoming frustrated, quick to anger, and from a motor standpoint, that you could also have increased arousal, emotion, and reactivity that can lead to things like reactive aggression. And we'll see this come out a little bit when we talk about different subtypes of ODD. So just think about how that might relate a little bit to ODD and other issues. So I think I'll move on. I'm not sure I have more to say, but I might refer back to this slide when later on in the presentation. So frustrative non-reward leads to irritability, and we see irritability across many DSM-5 diagnoses. So irritability and more broadly just maladaptive mood dysregulation. So you can see that in bipolar disorder, irritability is one of the cardinal symptoms that can be the presentation of a mania. In kids, irritability is commonly seen in depression, less so in adults. In oppositional defiant disorder, there's actually, the subtype, the more angry, irritable mood type versus the more argumentative, defiant type. You can see it in ADHD. And, so, I'm presenting, like Russell Barkley, the idea that emotional dysregulation is a core symptom of ADHD, with up to 50% of kids with ADHD really having big struggles with emotional regulation difficulties. And then we're going to talk a little bit more about disruptive mood dysregulation, where irritability, like persistent irritability, is like a core feature of the criteria. So with so many disorders with irritability being a potential symptom, how can we improve our knowledge about maybe what's really going on with this young person? And so there's many ways we can do this. And then this is just one example, looking at 5 disorders that we will touch on today. The ADHD with emotional regulation difficulties, that angry, irritable mood subtype, the DSM-DD, depression, we know irritable mood can be there, and then bipolar as well. So I'll just pick out one or two aspects of this. So looking at the typical age of onset, which is highlighted in red, ADHD, appears early in life as an heritable neurodevelopment disorder. ODD can, some typically develops, kind of a little bit later, a bimodal peak, sometime generally after the onset or identification of ADHD, and a later onset in adolescence. A DMDD is kind of defined. It shouldn't be diagnosed before 6, but should be there by 10 years of age. Depression, those data, and then bipolar illness, generally later emergence than depression. But a lot of adults can track their first symptoms to earlier ages. So almost like prodromal symptoms. And, put other things down here that might help people differentiate the irritability a little bit, associated features, the prevalence, that kind of getting at the horses and zebras, and then within a development span, when is the disorder first appearing. Another way we could look at, and this is again a lot of this research now going on with the NIMH with other researchers about how to further define irritability. So one of the big things, looking at is irritability as either a chronic kind of symptom that's there. Also, tonic is another word used there, or more episodic or phasic. And I made these pluses, I didn't really go for the data to look at. I just this is my best guess, maybe how these pluses appear, chronic versus phasic within these different diagnostic categories. But generally seeing kids with emotional regulation difficulties, including irritability, just having a lot of strong reactions to environmental triggers that, like Russell Barkley said, sometimes they can be very positive, it could be, they could have strong reactions that, to things going on that are funny or interesting that make them like a class clown. But what gets them in trouble is their negative reactions are really quickly explosive negative emotional reactions when things don't go their way. Whereas with DMDD, by default on the definition, you have to have both. You have to have these kind of explosions, this emotional sensitivity or reactivity, and you have this kind of persistent, irritable, angry mood too, which gets you to the diagnosis. And by definition, both of these categories are severe. And ODD, just to put two pluses on the angry, irritable subtype mood, assuming that maybe it's a separate diagnostic category from DMDD. But some writers argue, and I think in the ICD 11, they're not going to add DMDD. The kids that would be DMD in the U.S. and other diagnostic systems might be ODD, angry, irritable mood. But for now, I'm saying maybe they're separable. Maybe the chronic irritability and the episodic irritability of ODD is actually kind of not as severe as in DMDD. And finally, the bipolar part, and this is a distinction, really it goes back to the distinction between what researchers a number of years ago were calling pediatric bipolar, happening in very young kids, that led to a prevalence rate, in some cases, of 40-fold increases within a certain time span. Because they were defining these kids as chronically irritable, and that being some kind of new form of bipolar. And that's what led to the people at NIH to do the research on severe mood disorder. But I'm assuming when a person that has bipolar is euthymic, meaning they're not in an episode of mania or depression, they're not irritable. But once they are potentially manic, that's where irritability, along with elation or elevated mood, irritability can be a symptom. So that's one way I'm trying to kind of help us kind of see how these might present differently. So what risk, the research is looking at this, what risks do tonic and phasic irritability predict? So these two types of irritability are correlated, like they're not fully separable, but they can be separated to some degree. And so tonic irritability, that persistent angry grouchiness, predicts subsequent internalizing disorders. So that's the work of Ellen Levenloff with severe mood dysregulation. So instead of turning into bipolar kids, those SMD, as they grow older, are more likely to have depression and anxiety, whereas these kids that have the episodic irritability, these temper outbursts, and that can include reactive aggression, that predicts subsequent externalizing disorders such as ADHD, ODD, especially this other type of OD that's not necessarily the persistent angry, irritable mood, but the style that you sometimes see in kids that develop ODD that have had ADHD previously is this kind of argument, headstrong, defiant type. Also predicts conduct disorder, risky behaviors in females, relational aggression, and substance abuse disorders. And I'll try to pause here and make a little connection. So I think ADHD as an emotional dysregulated problem that's leading to frustration, that can lead to explosions, a lot of emotional reactivity and irritability. As an emotion, it's fairly short-lived, whereas a mood problem is a more persistent, long-lived issue. Emotions can usually be tied to an episode or like something in the environment triggered the kid. And so I part of the thing, I think it really depends, like what's the response within the caregiver child dyad when someone has an explosion. Do you have appropriate, good parenting techniques to kind of calm things down as soon as possible and get things back on track? Or is it a coercive parenting situation where the kid is not getting the carrots, they're getting the sticks, and they become more negative as a response, and you develop this cycle where they're, angry and upset and negative, and part of it is to get the parents out of their face, and that's what happens in coercive parenting. And does that work for a while? And then eventually, though, it develops into more ODD, that more argumentative type. They're always against anyone trying to correct them. So they, you get that first component of the emotional outburst, but then you develop over time, if you don't have the right intervention, of this more argumentative, no, I'm not going to do what you say, because they're still trying to get their carrots, even when they see their lives filled with sticks. So they still have agency in trying to get, make their lives better. And I think eventually that possibly, predicts some of the risk for depression in kids where that style eventually doesn't work out for them. And we may have more time to talk about that. So we've gone over, irritability. We've gone over emotional dysregulation. We've gone over all the disorders where, how we've, used our cookie cutters to kind of try to separate all these things. But as far as irritability goes, what are some general principles in transdiagnostic approaches? Because, I'm saying this as a non-specific, irritability is a non-specific symptom that goes across many disorders. So I wanted to offer you some kind of transdiagnostic tool. I think a more specific tool would be that specifically designed to help kids with DMDD is a study that was done using DBT on very young kids. And I think DBT is a good modality to think about because it really does work with people that have a lot of emotional reactivity. And then there has been one trial looking at a medication, based upon the concept of what SMD and DMDD represent, this kind of two model emotional reactivity, but also a persistent negative mood, looking at the medicines most commonly used to treat those separate conditions and seeing if they were used in combination, could that be a solution to the problem? So some of the general approaches would be, and I get this from Ross Green, is this attitude that all kids do well if they can, which opens up the door to looking at potential underlying causes of why they aren't really doing well. And from Ross Green, these could be lagging skills, it could be learning disorders, it could be environments that aren't really healthy and suitable for them. And it goes back to this principle: if we were designed to get as many carrots as possible and to avoid as many sticks as possible, it seems like if consequences select behaviors, you would think like all kids want to do well. No one wants to just get hit with a stick all the time. So just having a non-judgmental attitude, kind of agnostic attitude, and just being curious about what is going on with a youth that's having these problems. And in general, this is like an aspirational goal, knowing how, we're a complex organism with cognitive functionings like executive functionings. We have our emotions, which give us information about seeking something that's rewarding, but also, signals to ourselves like, if something's gross or nasty, avoiding that because it might be negative for us, like a food that doesn't look healthy. Learning to regulate our actions in service of our long-term goals, and also, figuring out when our reactions to events are actually taking us farther from our goals than closer. And then helping youth regulate their physiology in simple ways like getting the right amount of sleep, getting good nutrition, having good, healthy day-to-day patterns that can help regulate the physiology of ourselves that then will help us regulate our thoughts, emotions, and our behaviors. Doing this all together at the same time is the aspirational goal. So this is a little bit hard to understand, but do your best to use time development as your ally. And we'll see an example. Like Russell Barkley might say, kids with ADHD that develops at a young age, if things don't go well, like if treatment doesn't happen, 2 years later, they might be diagnosed with ODD. So they might have emotional reactivity now, but 2 years later, they might be developing some more persistent mood symptoms that are making the whole thing harder for everyone. So just knowing where there are opportunities in development to intervene, trying to do your best to forecast what might be coming down the road, might be able to nip some of these things in the bud. And sometimes you have to wait for developmental gains to be made that would be naturally occurring, but might be delayed in a youth. And like, for example, I remember with my son, before he was his cognitive abilities could regulate his emotions. When he would get frustrated, it could lead to a meltdown. But like a year later, a couple of years later, he would still get frustrated when he couldn't get something he wanted or was told to do something he doesn't want to do. And I could see the same frustration, but then he would suddenly it's like, okay, I'll do it. And so I could see he had some lag in development of his cognitive control over his emotions. But when he got there, then he was good to go. And in the meantime, though, things had not gotten worse before they started getting better. Utilize a spectrum and dimensional hypothesis approach, and when possible, to help understand underlying needs. So this is a little bit, maybe we'll see how this might be utilized a little bit further on, but I try to use in medicine what's called Occam's razor. Like if I can explain subsequent things by an initial problem, to me that's better than just adding more kind of diagnoses or problems later on. Russell Barkley would say that's true for ADHD with emotional dysregulation. It's inherent to the disease, so you don't necessarily have to add a separate mood diagnosis. Maybe later on, like 20% of kids do develop that separate mood diagnosis, but trying to conceptualize the problem as the dimension of the potential of the illness across the spectrum of potential disorders, knowing that some disorders over time, if not treated, will become a consideration in a differential. But just hoping through interventions across development that you can, just have the one disorder and not end up with multiple comorbid disorders on top of that. And then part of all my thinking about this is this quote, dichotomies are useful for education, communication, and simplification. Unfortunately, simplicity is useful but untrue, whereas complexity is true but useless. So I think as human organisms, we are very complex, so we develop systems like the DSM to try to simplify the complexity. And at the same time, we really need to observe the kid, react to the kid that's in front of us without overlaying too much of these DSM categorizations on top of a child and trying to see the child through that classification versus seeing the child that's right in front of you is kind of like the finger pointing at the moon. And when you get multiple diagnoses or multiple opinions, you get many different fingers pointing at the moon, but the moon is what we want to help. So that transdiagnostic tool that I want to refer, you can follow John Weiss to see how he's developed these kind of common elements that are effective across multiple diagnoses, such as ADHD, anxiety, depression. And so it's a mnemonic, feeling calm, helping kids, be calm, increasing their motivation for change through reinforcement, carrots that work for them, helping them see errors and thought processes, more able to do as a child becomes later adolescent, young adult, helping them with problem solving, referring to Ross Greene's collaborative problem solving methods, trying the opposite. You can see the utility of this, for example, exposures and anxiety, where the child doesn't want to do an activity because it's producing anxiety, but if they're able to accommodate to the activity, they will develop coping skills and actually get tangible rewards for doing so, in sense of being able to engage in things they want to do anyway, like make friends at school and et cetera. And behavioral activation is a likewise principle used for youth suffering from depression. Here's a model that I think shows a lot of promise. It was used for a trial of kids diagnosed with DMDD. The target population were much like the kids we see with emotional dysregulation with ADHD. It's highly emotional sensitive, a low threshold to trigger them, and then a big reaction that happens very fast, very tense, and then with a slow return to baseline, and having problems with their behaviors, such as frequent temper tantrums, like we see in ADHD with emotional reactivity, but also some of the behaviors becoming self-harming behaviors possibly being a result. And so the hypothesis with these kids, that kids are especially emotionally sensitive, have to be able to withstand the double impact of any stressor. Like any of us, when we're presented with a stressor, it's going to have an emotional impact on it. But if our emotional reaction is very strong and overwhelming, not only to the kid, but to the parents or to the caregivers, it's just too much for this particular child. So we have to be, our approach to this child has to be a little different than someone that doesn't, have such a strong emotional response to a stressor. And so their approach is, for example, knowing that many kids with ADHD have adults with ADHD, and if those kids have emotional reactivity problems, maybe the parents do too. So we have to help the parents be able to regulate emotionally. We have to create validating environments for the child, and I see almost like environments like a rubber room, with all soft, bouncy edges, where things don't escalate further, versus like a room in reality that's all sharp edges and walls. Just knowing these kids have more challenges in being accommodating to those. And then once we have them in a euthymic state, they can practice something like the first skills that I mentioned from John Weiss earlier, and hopefully be able to self-regulate better going forward. This is a study that was the medication study I was talking about. It was an 8-week randomized controlled trial. So they added an antidepressant for kids diagnosed with that SMD, DMD construct. But before they randomized them to an antidepressant, they treated the kids with methylphenidate for ADHD. 80% of the kids had ADHD. So they had that pre-treatment with a lot of improvements in the ADHD symptoms, but also those emotional regulation disorder symptoms in terms of the outbursts, that phasic episodic irritability. And then they were randomized to placebo or citalopram up to 40 milligrams. And there were improvements in the citalopram group in terms of their irritability symptoms. More kids than than in placebo responded. But the way they set up the study, when they looked at functional outcomes, they just didn't see a huge difference between the two groups, which was disappointing. So we may have some early ideas about how to treat kids that have both emotional reactivity that's often seen in ADHD that responds to stimulants, but also the persistent mood problems that we categorize or conceptualize more as like a depressive disorder. This study, didn't lead to a major kind of change because it just didn't provide enough positive evidence about what to do next. The horses and zebras that I would want to talk about is in terms of emotional dysregulation across a spectrum. And so horses are common, zebras are rare. But this is, again, I want to try to go back to this concept of looking at a potential spectrum of mood disorders occurring across development. At the end of that developmental period, you might get to that zebra bipolar disorder, but early on you have the more horses like the ADHD with a family history, maybe with emotional dysregulation. So my push here is how can we intervene earlier to kind of do interventions that can maybe arrest the further development of psychopathology as the person gets older. And again, knowing how the symptoms of bipolar listed on the left, how common they are in ADHD, and so knowing maybe how we can help kids with ADHD with emotional dysregulation is, maybe should be the horse we're treating and not to rename it a zebra just because they're having these symptoms. But zebras do occur, so I wanted to add this slide. Are some ways that you might separate what could be a higher risk for pediatric bipolar versus a lower risk. And knowing family history, first a parent or a twin sibling, that increases your risk. Increased energy and decreased need, kind of like with Max we were talking about earlier. And for the sake of time, I would like you to look at these later, but I think these are some, if you are worried about the zebra out there, these are some ways to kind of differentiate, to increase the risk or decrease the risk based upon those characteristics. So we were looking at these kids earlier, and Max, Andrea, Johnny, Bert, and Stacy, you could take a second to think about like how you would map them onto a potential diagnosis. And for the next slide, I kind of did it on my own. So this is how I diagnosed these kiddos. And I just wanted to, one more minute, maybe think about what would have been or were some of the appropriate treatments and maybe some treatments that aren't appropriate. Like, so for Max, he didn't really show any ADHD symptoms or disruptive behavior. He did show signs of depression at an early age that deserved treatment. But then there's been some flags over the years. And so I think, he should be, will be evaluated for concern for a unipolar disorder like depression versus a bipolar mood disorder, which I think pretty clear that that's probably what's going on with him. With Andrea, she was referred for episodic aggression, but it wasn't due to ADHD. I think looking at, investigating why she's so reactive in the school setting could lead to a diagnosis of an anxiety disorder. Johnny, he had pretty clear evidence of ADHD and responded well to medicine. He had maybe some evidence of emotional dysregulation, and maybe parent management training could have occurred before a stimulant trial. But he's responded really well. Bert O, I think, had the oppositional defiant disorder, the subtype being angry and irritable. And he could have benefited from parent management training. He didn't respond to a stimulant. He could have been reevaluated, but now he has depression, which is a risk factor for that subtype of ODD. And whereas Stacy, I think she showed, clear evidence of emotional dysregulation difficulties. She should have had BMT. She did have ADHD and responded so well. She's been diagnosed with depression. That might be part of how she's presenting right now. But I don't think she's bipolar, and I don't think she should be started on lithium. So there's some examples of how I would think through things. And I think those are all my slides.
Wonderful. Thank you so much, Dr. French. I had a hesitation there as I was still taking notes. My notebook is full, and we have quite a few questions. So I will just very quickly, once again, thank our sponsor for today, Microvita, before we head into our questions and a quick look at the survey that we asked at the outset of today's conversation. The number one most cited challenge for your child or your patient was the dysregulation of emotions in the moment. So sort of subjugating feelings. And number two was the intensity of emotions, a sudden violent outbursts. And those were really the leading concerns here today. So we absolutely touched on the root causes of those as well as interventions. And I want to just underscore, we got a question from a listener here today that kind of cuts to the point. Can you stop a horse from becoming a zebra?
Yeah, that's a good question. I think like for Max, I think it might have been hard, but and perhaps though he could have been identified as someone at risk for bipolar in that first cycle, when he had some sleep disturbances and some mood changes. I think if someone was really like, his grandfather has bipolar, not necessarily that they would put him on lithium, but there's something called social rhythms, interpersonal therapy for people with bipolar. He could have been conceptualized. And I did read recently, mania in adolescence doesn't always persist into adults. Like, a manic episode doesn't have to turn into adult bipolar. And there's, other types of mania that occurred from drugs, et cetera. So I think there are ways to potentially take a horse and keep it a horse.
Okay. That's helpful. And there were quite a few questions about whether stimulant medication has any adverse or helpful impact on DMDD specifically. In other words, is there any concern that side effects associated with a stimulant medication could worsen symptoms of DMDD, or is it more likely that it could create an environment in which a child is more likely to be able to learn those first, coping strategies that you went over?
Yeah, good question. I think in that study we looked at, they pre-treated those kids with stimulants before adding citalopram, and they did see. That's what you'd normally see with kids that are have ADHD symptoms plus the ODD-like emotional reactivity, that those, and even reactive aggression, that can all improve with stimulant treatment. So I think indeed DMDD, to the degree that ADHD is really present, then treatment with a stimulant can help both, just the core ADHD symptoms and the emotional reactivity of that's associated with dysregulated emotions in ADHD. But like in that study, they didn't try to treat the persistent mood problems. That's where they added citalopram. But stimulants can, they can blunt mood, like the zombie effect, where stimulants can blunt the experience of emotions. And in rare cases, stimulants can make a person's mood more irritable. But a lot of times kids tell me they feel calmer on a stimulant, but you do see irritability in stimulants, so you can't deny that. But it's maybe hard to predict where a trial will cause irritability versus the opposite of the kid coming back and saying they feel calmer.
Okay. And if a child has really no reaction to a stimulant, as I think one of your first example, no reaction to stimulant or non-stimulant, should the parent assume that ADHD is not the root and look for alternative diagnoses?
That's a tough question, but I think you almost have to, from a predictive standpoint, say, like, let's look for other sources of the problem. But first of all, a child, if they were started on a methylphenidate product, don't respond, should be tried on an amphetamine product, because some kids respond differentially. Yeah, and they should have legitimate trials of non-stimulants like alpha agonist and atomoxetine. And I suppose there could be some type of, genetic reasons why they're poor responders. That is something maybe in the future of the medicine, personalized medicine, will be able to get to. But I would say if you do legitimate trials and you're just not getting a response, and then if there's not some environmental thing that would make any person not be able to respond to a stimulant, then I think you should, start broaden the differential and try some other approaches, and not just, belabor the ADHD diagnosis when it's just not panning out. Right.
A number of parents here also have a diagnosis, or their the child's one of their biological parents has an ADHD diagnosis as well. So as you stated, emotion dysregulation can be a problem with the parents as well. Could you define the coercive parenting style that you spoke about, and perhaps some ideas for how to reverse the impact of that?
Yeah, just a punitive parenting style that, kind of models the behavior that you don't want the kid to learn, like, emotionally reactive, criticizing, not validating. And then the kids, what's interesting about behaviors, kids can still try to influence behavior in a negative way. The best way is to get the carrot, but you could still come back. It's called negative reinforcement. You can argue with your parent to a place where they're like, okay, you can have the keys, go take the car, whatever. I just give me a break. And so that kid has learned the behavior. Upping the ante, is the behavior that I need to do to get my carrot in life. And so that cycle is this very, kind of maladaptive for the whole family context. And so that's kind of the definition. I think, if a parent has emotional dysregulation problems, get treatment for that. Like this idea, like let's create a bigger space for all of us in terms of, being kind of trying to be more understanding, using collaborative problem solving by Ross Greene, trying to, erase all your memories and behavior patterns that have developed over the year and look at it as a blank slate that, kids do well if they can. So really trying to, kind of come up with version 2 of what our family context looks like. And maybe some of that involves apologies. Like, I've been too hard on you. I know I've underestimated how much this disorder has made it so hard for you to regulate your emotions. And I have to admit, I've been sucked into that and hooked for years now. And I want to restart, are you willing with me if I learn some new techniques? Are you willing to let us, be a family again? Try to make it work.
I think that's a wonderful piece of advice. I'm going to try and squeeze in one more question, probably against my better judgment. But we got a number of questions from folks who said that their child is actually able to control their emotions fairly well during the school day. But when they get home, they can become physically and verbally aggressive and have these sort of extreme reactions. They are wondering if this is a sign of, a medication drop off. Is it that kids just feel more comfortable at home so they can let their guard down? Or could that be a sign of something else?
Yeah, it's all of the above. And the something else could be like, the girl with anxiety, is able to maintain it while at school, but, after she gets home is unable to maintain it because there's so much that emotion that wasn't expressed at school that is bubbling out at home. Definitely medication rebound, definitely familiarity, and maybe, seeing if emotions are a way to communicate. What is, just saying, what is the communication here? What is going on? And trying to use collaborative problem solving and to broach that in terms of, is there another way we can communicate our emotions without aggression, and being that rubber room enough where you're not emotionally reactive. You want safety in the home, but you're not overreacting to a display of someone's dysregulated emotions. It's like, oh, let's talk about this.
Excellent. Well, I'm sorry to say that we are out of time, but Dr. French, thank you so much. This was such an exhaustive and really, really insightful overview of a very complex mix of conditions. So thank you for this presentation, and for everyone who joined today. And sign up for our alerts at attitudemag.com/newsletters so that you can learn about all of our upcoming events. If you are listening in replay or podcast mode, visit attitudemag.com and search podcast 435 to access the slides, webinar replay, certificate of attendance option, and the transcript. If you are still shopping for gifts, Attitude Magazine is offering a 2-for-1 subscription deal now through December 31st. Visit attitudemag.com now to get 2 subscriptions for the price of 1, maybe for a family member or as a holiday teacher gift. Thank you again, Dr. French, and happy holidays to everyone.
Thank you for inviting me.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.